All right. Sorry. Hopefully this works. Okay. Sorry about that. I feel like that's why I always leave a cushion for like tech stuff too, just in case. So hopefully everyone's able to get back in, and we will just jump into the webinar. I'm so excited to chat with you all. I love it when people get fired up about their births and when they're just really excited to learn and to grow and to start planning what that's going to look like for you. Because we all know that you can't predict how your birth is going to go, but we can do what we can to help you feel empowered and in control of what you can in that moment. So I'm going to go ahead and start the presentation, and then like I said, if people are adding on, we'll just bring them in while we're doing this. All right. All right. Can you guys see my screen? Yep. Okay. Cool. Like I said, I'm super, super excited. I love talking about birth. Most of you either have heard about this from either the podcast or for following me on Instagram. So obviously this is a really, really big passion of mine. And if you're here, it means that you want to learn about what you can to take control of your birth, what your options are, and what that can look like for you. This webinar is for you if you're the type of person who does want to grow and advocate and know what their options are going to be when it comes to your birthday. And make sure that you stay with us till the end. There is the giveaway at the end, and we're going to be doing some Q&A. So if you have questions that come up for you along the way, you can either drop them into the chat as we go, or just hold on to it for the end. But I'll get to everything at the end. And I already warned you at the beginning that I'm pregnant and I'm out of breath. So bear with me as I catch my breath while I'm talking, and most of you are pregnant, so you know how that goes too. It's like all of a sudden it just hits you one day, you like go up the stairs and you're like, oh my God, like how come I can't catch my breath? I feel like for me, it hits like as soon as I take a pregnancy test. It's like all of a sudden I'm just out of breath. But I'm really, really excited to go through this with you guys. And this is all about 3 research-backed options to include in your birth plan to reduce your risk of having a cesarean. There is some evidence on that. There's a lot of research that supports this. So I'm really, really excited to get into it. And this time in your life, it is like so exciting, right? Like everybody's so excited to have a baby. We picture our wedding day, our career, you picture that day that you get to hold your baby and say, oh my gosh, I did it. But there's also things that come up. What if your plan doesn't go accordingly? What if you do need an intervention that you didn't plan for? And what if you do need a cesarean? So we are going to talk about some of those things as well, and also help you understand that even with the goal of this being to reduce your risks of having a cesarean, that they are there for a reason. But you need to be in the driver's seat of your birth to be able to advocate for yourself and know when that might be the right choice for you and whether it's like an unnecessary intervention that is happening. Like I kind of said at the beginning, this webinar is for you. If you know what birth you want to take ownership, you're ready to learn and grow and advocate for yourself and your baby. And these are going to be the giveaways at the end: some Earth Mama nipple butter, the best nursing tanks. I am a huge fan of hand-me-downs, so I got so many different nursing tanks handed down to me. But a friend ordered me one of these and sent it to me, and it was by far the most comfortable, best nursing tank that I ever had. So I'm really excited to give those away. And then some labor prep tea as well. And if you are the winner of that, I'll tell you a little bit more about that as well. So what we're going to go over during this workshop is going to be understanding what cesarean sections are, where the rise kind of started, and where we're at today in the United States with them, the importance of having a birth plan, evidence-based practices, speaking with your provider, and involving your partner. The goal for this webinar is to feel confident in yourself, in having the birth that you want, that you're going to feel empowered to advocate your needs and your wishes, that you feel in control no matter the outcome, and that you feel inspired to find out the rest of your birth options. We're only going to go over a few today, but there's a ton in a birth plan that can really help you, guide you in having your birth experience that you desire. And at the end, I have some really exciting news to share with you guys about my birth plan prep course coming out and some one-on-one coaching calls that I'm doing, but we'll save that for the end. And I want to start by saying that cesareans save lives. They are a complete valid way to give birth. Maybe some people here have had one before. We all know somebody who's had one before, and they are definitely there for a reason. There are several reasons to have a cesarean, and only a few true emergency C-section reasons. But I don't want anyone to feel like this is a webinar bashing on cesareans, because again, they are very important. We do need them in our birthing system, and they do save lives. So I'm going to tell you a little bit about me before we dive in and what brought me into this work, and why I am so passionate about it and why I could talk about it forever. So the first birth that I ever witnessed was the birth of my nephew. My sister ended up having a home birth with my nephew, who's now 15. Oh my gosh, 15 and a half. And that was the first time I had ever witnessed birth. And it was such a crazy experience at her house with her midwife, very long and hard labor. But I was like, holy crap, like this is intense. But shortly after that, it was like such a beautiful and peaceful experience, even though it was a hard and long labor. Shortly after that, all of my friends started to have babies. My sister and I are pretty close in age. A lot of my friends started to have babies in their 20s, and everyone was ending up in a cesarean. And I'm like, what is happening? And they would end up telling me things like, my doctor told me that my pelvis is too small, I have to get a C-section, or that my baby's too big, or, we looked on an ultrasound, the cords around their neck, so we have to have a cesarean birth. And to me, it just didn't sit right. Like, I'm like, I feel like this isn't how birth is supposed to go. And come to find out, I was living in Nevada at the time, in Las Vegas, and I circled it on here in 2012. Nevada actually had the highest C-section rate in the country at the time. It was 35%. So it makes sense that most of my friends going to give birth were ending up in cesareans. And so that really propelled me into doula work. And I took my first course in 2012 and just knew that this was going to be a part of my life forever. Even though I didn't start doing it full time then, I just started to get really, really passionate about educating women on their options in birth. And then I moved to Chicago in 2018, and I actually got hired by a midwife group here to work in a hospital as a doula full time. And I learned so much watching them in their births as well. It was so honoring to be able to work alongside these midwives and to feel so welcomed in a hospital setting. We still live in a time where sometimes I walk into a birth and I don't know if that OB is going to have an issue with doulas, if some of the nurses have issues with doulas, because I've been at ones before where things have been said to me. And it was just so nice working in this hospital where the nurses were excited we were there. The midwives were excited that we were there because we could all work as a team together. And I learned so much from being at that practice. And I had my first daughter in 2020 with that practice that I worked at. And I had been a doula for a long time, prepared, knew all of my options going into it. And as soon as we got to the hospital, the nurse told me she was going to place the hep lock for the IV in my hand. And I just let her know that I didn't want it. And she argued with me back and forth for like 5 minutes, like a long time. And my husband's like going back and forth, like, what is happening? And it's really easy to feel submissive in that. He's like, babe, like, is this something that you need to get? I mean, the nurse is saying you have to get it. And I'm like, no, I don't. Like, I know my options. I don't want to be feeling this in my hand while I'm laboring. I don't want it. And finally, my midwife walked in and was like, she doesn't have to have that. And the nurse was like, okay. And it wasn't until after my birth and processing everything that I'm like, even being informed and even knowing all of my options, I can see how it's so easy to give up power in that setting. And how, as a doula, my original training that I took taught us that we aren't supposed to advocate. We're just supposed to inform our clients. But that's when my mentality really, really shifted. And I'm like, no, I am an advocate. Like, if it comes to something that my client needs, and when they are being medically coerced or fear-mongered or lied to or pressured into something that they don't want, absolutely that is my role. And my role is also to empower you to advocate for yourselves, to let you know it's okay to speak up for what you want. And another thing happened a little bit later in the birth too. So choosing my birthing team was really, really important and really saved me actually from having a cesarean with my first. I was about to push my daughter out, and I just remember a nurse running into the room and telling my midwife, like, the OB wants to know why you're not prepping her for a cesarean right now. And I'm like, what is happening? Because I knew that the baby was experiencing some decels. She was having a hard time recovering after contractions. And the midwife looked at her and said, she's pushing the baby out right now, and just like really advocated for me in that moment. And within the next few pushes, she was out. And we're going to get into that a little bit later. I'll reference this again, the fetal monitoring and how that actually contributes to higher C-section rates. But again, if I didn't know my options, if I hadn't chosen the right birth team, my birthing outcome would have been very, very different. So I did learn that I have to advocate. And I've really also found that having somebody to talk to outside of yourself helps too, such as a doula. But before this birth, I was at one birth before that almost made me quit being a doula. And I had never been at a birth where somebody was treated so awfully. The nurses laughed at her birthing plan. The midwife came in and told her that if she didn't get a C-section, because her water had been broken for 24 hours, that her baby was going to die, which isn't backed by research. She had 0 signs of infection. Her family was so not supportive. Her mother had had C-sections, her sister had C-sections, and they didn't understand why she was wanting to have an unmedicated birth. They kept telling her, why are you doing this? Just get the medicine, just do this. You're tired, get the C-section. And she eventually ended up getting a cesarean, and her sister said, I told you that you'd probably get a C-section. And so choosing who's in that room with you, choosing your birth team is so, so important. And that birth almost made me want to quit. I remember going outside a couple of times and calling my husband and crying because I'm like, I don't know if I'm cut out for this, because I didn't know that I could advocate. I didn't know where I could step in and where I couldn't. And looking back now, I wish I felt the empowerment that I feel now to talk to my client and to be like, we need to kick your family out. We need to do this and like set up these boundaries to really create that birthing space for yourself. And so since then, I have seen changes in my clients' birthing experiences, just really helping them advocate, and me being that sounding board that they can come off of. So I'm really, really excited to go through this with you and to go over all of the information. So we're going to start with what is a cesarean. I'm sure most of you guys know what a C-section birth is, but we'll just kind of talk about like what the actual title is. A cesarean section or C-section is the surgical delivery of a baby through a cut made in the mother's abdomen and uterus. And it's really interesting because when you Google reasons for a cesarean, there's very few true reasons under the emergency cesarean section. And a lot of reasons also depend on your provider, your health, and your views of birth. Because there are a few reasons also that there's going to be a planned cesarean. Let's say you have placenta previa. That means that your placenta is blocking your cervix. That actually is a reason to get a cesarean. However, that's not going to be in labor. That's going to be something that's planned or scheduled in the future. So there's the planned, there's the emergency, and then there's the ones that happen that don't necessarily need to, that are based on your provider, your health, and things that arise during your pregnancy and labor. So this is one of my favorite statistics to share, is that the World Health Organization says that a country's cesarean rate should not exceed 10 to 15%. 10 to 15% of all live births fall into a risk category that involves a cesarean. The United States cesarean rate in 2019 was 32.1. So that means that almost 20%, or 1 in 5, is an unnecessary cesarean that is happening. So these are the trends in cesarean rates. And if you look in 1970, it was at 5.5%. And it skyrockets in the 80s. And then in the 90s, there's kind of a lull. And what's really interesting, I mean, it's gone up since 2019. It's plateaued a little bit, or 2009 to 2012, it started to kind of plateau. And then it's just slowly gone up like 0.1, 0.2, things like that over the last few years. But what's really interesting is when you look at graphs like this, you can kind of match it to trends in birth when certain things were introduced. Like in the 90s, where like 1999 happened, a little bit after that, they put up stricter laws in hospitals against VBACs. So they weren't allowing them as much. Even now, there's hospitals that just have a no VBAC policy and things like that. So you can see that it skyrockets there. We're going to see later, one of the things in your birth plan is intermittent monitoring. When that was introduced in the 70s, when continual monitoring was introduced in the 70s, that's when the cesarean rate started going up. So it's really interesting to look at these trends and see what happens. But this is also another one that I like to look at, is the maternal mortality rate in the United States. It sucks to look at because it's like, why are we going up? Right? Like with how far we've come as a society, why is this going up? But this also matches the trends in the medicalized system. You see that we're already on a decline. And then with the introduction of more cesareans, the introductions of different interventions, it slowly starts to rise up. And you can see even from 2019 to today, in 4 years, our maternal rate went up so much. I also think a lot of that had to do with COVID, with people being denied birthing partners, with people birthing alone, with so many things happening that maybe weren't handled right, and women feeling like they couldn't advocate for themselves as well. Hospitals being strict, so if there was a problem when they went home, they didn't want to go to the hospital because you're scared of getting COVID, and more women were dying. So I want to look at here the difference between obstetric care and midwifery care. There's a lot of research showing for low-risk pregnancies that there's a huge difference in care. So the low-risk cesarean delivery rate among first-time moms that are full-term with one baby head down, so this is not including breech babies, which is a different section of cesarean delivers. In 2022, the cesarean rate was 26.3 with obstetric care. Cesarean section rate for women receiving care in birthing centers across the United States ranges between 5 and 10%. The birthing center that I went to that's here outside Chicago, theirs is like 8.7. So most birthing centers fall within this range that the World Health Organization talks about. For low risk pregnancies, the C-section rate should be around 10%. However, in the obstetric model of care, it's 26.3. Like I said, that's not including breech births, which would automatically be a cesarean in most of those. And so it's just very interesting to look at the differences. So again, who you're choosing as a provider, the model of care you're going through really, really matters. So a lot of people know about short-term effects of cesarean, the scar healing, and different things like that. But looking at the long-term effects, there's a lot that can happen that your provider might not be telling you. So in that moment, when they're like, hey, you have a big baby, we need to do a C-section, because your baby's at risk for shoulder dystocia. Okay, what's the risk of shoulder dystocia happening versus what are these short-term and long-term risks of having a cesarean, which are secondary infertility, dense adhesions, 50% more likely to need a hysterectomy, scar infection that can appear months to even years later. You can even have an underlying infection brewing in your scar that affects secondary infertility, and an increased chance of developing endometriosis. And then for the baby, research shows that babies born via C-section have a higher rate of type 1 diabetes, a lower academic performance at the age of 8, lower rates of breastfeeding, impairment of the initial bonding time, decreased immune function up to age 7 due to not passing through the beneficial flora in the vaginal canal. Again, though, we all know people who have had C-sections, and it's like, well, their kids are smart, they're doing fine. And it's like, yes, most of them are, but these are risks that like can be involved and definitely are affected by cesareans. Oops. Okay. So now I want to talk about what's a birth plan and why do we want one? If you look up the definition of a birth plan, it's going to say something like a birth plan is an outline or a template to let your providers know what your preferences are. I believe that the birth plan is a guide to educate you on your labor and birth options and empower you to research what you want, so that you can make informed decisions. So it's so much more than just a template of yes, no, yes, no. It's you researching and knowing what your options are, feeling empowered in making these decisions, so that you can be in the driver's seat of your birth. I want to talk about misconceptions of birth plans. A lot of people think that they don't need one, that it's only if you want an unmedicated birth, which is very not true, that doctors and nurses won't look at it, or if I'm a go with the flow, then I don't need one. Even if you want an unmedicated birth, or if you want a medicated birth, let's say you're like, I'm going to the hospital, I'm getting an epidural, that's how I'm having my baby, whatever else happens, happens. There's still, again, so many things on the birth plan that you need to know your options about. And the epidural isn't a guaranteed. I've been at a lot of births where the epidural didn't work. Do you know what your other pain relief options are? Do you know what else you can do? What happens in that case? What if you get there and they're like, we can't give you the epidural yet? What if your birth actually goes really quickly and you didn't have time to get one? There's so many reasons to still have a birth plan. And it doesn't just include, people think it just includes like pain management. It's in case of induction, in case of cesarean, your newborn procedures that are going to be performed. So it's giving you options on each of these, and so that you know exactly what's going on and you feel empowered. The benefits of a birth plan is that it's going to give your provider an understanding of what you want. It informs you on your options, guides you to think through your birthing preferences, helps you feel empowered, and then, like I just said, includes plans for the induction, newborn care, postpartum, in case of cesarean. So it really is full of everything that you're going to need. It's not just, yes, I'm getting an epidural, or no. There's so much more. So even if you are go with the flow, you still want to know your options, because that's when decisions start being made for you. And you might not know what the risks or repercussions are. And so it's really, really important that you're aware so that you can give informed consent in your birth and know what is going on. All right, so let's dive into the nitty-gritty. 3 things to include on your birth plan to reduce your risk of a cesarean. The first one is, as I mentioned, that in case of induction, bullet point. I know that it's called a birth plan, so people think it's just for the birthday. Like I said, it's all those options beforehand. So in case of induction, the rate of induction of labor in the US has risen from 9.6% in 1990 to 25.7% in 2018, including 31.7% of all first-time births. So if you're a first-time mom, you really have a higher risk of being induced. And most birth workers that I talk to actually think that these numbers aren't correct because like everyone that they know is getting induced. I was even at a birth last year at the hospital and my client was laboring and they were like, oh my gosh, this is so fun to watch. I'm like, what do you mean? And they're like, we pretty much just get inductions. And I'm like, really? They're like, yeah, we get pretty much all inductions. So it's fun to watch somebody going through spontaneous labor. And I was like, oh my gosh, I had like no idea that many. I mean, I kind of had an idea, but I'm like, that many are really getting induced. So a lot of us birth workers think that this number is actually pretty low. I would say the majority of my friends have been induced. Almost everyone I know has been induced. So it's definitely a little bit skewed. Inductions are highly pushed by providers due to the ARRIVE trial. Cesarean numbers achieved in the non-induced group were well below the national average. So I'm going to talk about like a few of the flaws in this trial, because a lot of providers will say, oh, well, the ARRIVE trial shows that that you should get, an induction because it's going to decrease your risk of cesarean. So in the ARRIVE trial, the group that they induced at 39 weeks, this was first-time moms who met certain criteria. They induced at 39 weeks, had a 19% cesarean rate, and those who they let continue go on had a 22% cesarean rate. So the conclusion of this trial was if you get induced at 39 weeks, it actually reduces your risk of a cesarean. This is why that is highly, highly flawed. It was even the non-induced group, their number was 22%. That's over 10% the national average. So how did they, in this trial, achieve such low numbers? It's because they knew that they were being observed, and so they were using other methods to provide an even greater reduction in cesarean rates that don't involve inducing. So they were only using certain methods of induction and only taking on certain people, knew that they were being observed, so they acted in a certain way. That's not how our providers act. They're not taking all these things into consideration. They're just saying, oh, this trial said at 39 weeks, you should be induced. What's actually happened since this trial is cesarean rates are increasing since this came out, especially for first-time moms, which is limiting then your options in subsequent births, unless you find a very VBAC supportive provider. There's so many things out there that you can see where the ARRIVE trial has actually created more C-sections versus reduce them. And another thing that this trial didn't do was take into consideration the mother's preferences and satisfaction. Okay, so there's a 3% difference in this trial. What does that even mean? Your doctor's just like, hey, you need to do this because it's going to reduce your chance of a cesarean. But how do you feel about it? Did you want to have an induction birth? How's your satisfaction going to be after that? That's a huge consideration to take when it comes to your birth as well. So another reason that the providers are going to say that they want to induce is for due dates. So I absolutely love this chart because I hear it all the time. Actually, recently from a friend of mine, her sister was over 40 weeks and her provider told her, as soon as you hit 40 weeks, you need to be induced because it's like the baby smoking a cigarette in your womb every day. He told her this. And then he said, once you get to 41 weeks, it's like your baby's smoking a pack of cigarettes every day. And I'm like, when she told me this, I actually have a recording of him saying it. My mind is like blown. And of course, I'm like furious because I'm like, that is complete fear mongering and medical coercion. And when you actually look at the data here, so my friend's sister was under 35 and healthy. You can see that the stillbirth rate is higher when you're like 20 to 23 weeks. And then it drops down between 32 to 33. And then it slowly kind of goes up. But at 40 weeks, you can see in every single group, except for those over 40, the stillbirth rate actually goes down at 41 weeks. And providers don't share this information. They just say once you're 39 weeks, your risk of cesarean goes up, or your risk of stillbirth goes up. And that's not true. According to the data, if you're under 40, even if you're really healthy or just average, your risk of stillbirth goes down at 41 weeks. The stillbirth numbers were also affected before when we had less, when doctors weren't telling us what we were supposed to be doing, such as counting those fetal kicks, maybe doing a non-stress test based on your age and where you're at gestationally. But also the risk is up to you. You might look at this chart and say, okay, I'm 35 to 39. I'm pretty healthy. I can see from 37 to 38 weeks, it goes up a lot, right? To almost between 1 and 1.5. And this is 1 in 1,000. So the statistics are still like 0.002 something. That's up to you to decide what this risk is, not for a provider to decide for you. If you think that this is too risky, let's say you're over 40 and you're like, wow, I can see that it starts to really go up. Maybe I do want to consider an induction. That's fine. But again, this is information for you to have to determine your own risks, to figure out what's best for you, because inductions do lead to higher cesarean rates. And one reason will be the ARRIVE trial. The other one will be for due dates. There's other reasons they're going to want to induce, such as big baby and other things. We're not going to get into everything right now, but this is just to kind of show you how things are pushed. Also, inductions are highly paired with Pitocin. So Pitocin is synthetic oxytocin that's going to mimic labor and cause your uterus to contract. And Pitocin is actually considered a high-risk medication. And one of the main risks is fetal distress. So once you have Pitocin, you're more likely to have fetal distress, and fetal distress leads also to higher cesarean rates. It causes your uterus to tire out from being overstimulated, overworked, depending on how long you've been on it. Again, there is a time and a place for sure for Pitocin, but the way that it is used now with inductions and with almost every single birth is not friendly to your birth plan. Also, a lot of people don't know that Pitocin is not FDA approved for induction. It's approved to be used in birth for different things, but it's not approved for induction because of the outcomes. But yet, even a friend told me today that they're talking to their provider, they're due next week, that the doctor was like, okay, well, if you don't have the birth in the next week, come in, we'll induce you, we'll start you on Pitocin. And she's a first-time mom. Her body's never experienced what that real oxytocin contractions feel like to go through. Inductions go a lot smoother in second, third, fourth time parents versus a first-time mom. But again, inductions in general can still lead to more interventions, which can lead to higher cesarean rates. The next thing to include on your birth plan is intermittent monitoring. So you have the option of intermittent versus continual monitoring. Intermittent fetal monitoring involves checking the fetal heart rate every 15 minutes during your first stage of labor. So that's when you're between 1 and 9 centimeters. And then the second stage of labor, which is while you're pushing, they're going to check every 5 minutes. And in this picture, it shows you what the Doppler is. So it's when you go to your prenatal appointments, when they're using that Doppler to check the baby's heart rate. That's what intermittent monitoring is. Continual monitoring is when they strap the strap to your belly, and it's an electronic monitor that continually is hooked up and taking all of the readings. And we're going to talk about why this is important. So most hospitals automatically use continual monitoring unless you request otherwise. And of those attempting a vaginal birth, 86% in this trial had electronic monitoring. And in randomized clinical trials comparing electronic, so continual monitoring, with intermittent monitoring, continual monitoring increased the risk of cesarean by 63%. So this suggests that if electronic monitoring had not been used in 620,000 women, 240,000 fewer of them would have had cesarean deliveries. So that's a huge difference. That's like a big, big statistic. It is very widely known, easily Googleable, if that's a word, Googleable, that continually monitoring leads to higher C-section rates, but not better fetal outcomes. So it's not doing you a service by being there. This is what it looks like. So if you've had a birth before or you've been in the hospital, it's going to be that top line. The bottom line is your contraction line. And what's interesting that a lot of people don't know is this actually doesn't measure the strength of your contractions. You could see a huge wave on there and be like, oh my gosh, that was a huge contraction. That's actually not measuring the strength, just the length and the distance. Up top is the baby's heart rate. So what they're looking for is a baby in distress. And you can see that after the contractions or between them, the baby's heart is dipping a little bit. Some of that is very normal. They want to see variables in the heart rate. They're going to see some decels. They're going to see some of that. The thing is that providers don't agree on what's normal and what's not. And that's why some of them are going to jump in, and there's not like a hard line of when the baby's heart rate looks like this, jump in, or when the baby's heart rate looks like that. They all have differing opinions. So again, it's going to go back to like what provider you have. But that's what they are looking at. And also the continuous electronic fetal monitoring was developed in the 1960s. So they developed it to reduce the incidence of neonatal seizures, but that was to help decrease cerebral palsy or neonatal mortality, and it didn't. There was no benefit, no beneficial effect in decreasing cerebral palsy or neonatal mortality. So basically, continual monitoring just leads to higher C-section rates without better fetal outcomes. Hold on, I'm going to go back to this really quick because again, this was what I referred to at that chart at the beginning. This was developed in the 1960s. So you can see this started in the 1960s. It takes a while to like start getting picked up and practice different places. So 1970s, starting to really be used all the time in the 1980s. That's also again where you're seeing that huge skyrocket in cesarean rates at the chart at the beginning. All right, so the third thing, and this is kind of a tricky one because I said 3 things to include on your birth plan. This isn't something you're going to include on your birth plan, but it's how your birth plan is going to help you determine this. But choosing the right provider, this is the #1 way to reduce your cesarean rate. And so what you're going to do and why this matters is you're going to make your birth plan and use it as a template to ask your provider questions. You're going to learn their philosophy about birth, and you're going to ask open-ended questions. So you can't just go in and ask your provider, are you going to let me go past my due date? And they're like, yeah, sure. You have to ask questions like, how do you feel about induction for due dates? What do you view as a medically necessary induction? How do you view using Pitocin? How do you view freedom of movement? How do you feel about this? How do you feel about that? It's open-ended questions to make them actually answer you. So I'm a big fan of getting that birth plan done as soon as possible. I know some people are like doing the next week or so, but getting that birth plan done as soon as possible so you can use it as a template to talk to your provider about what your wishes are, just in case you want to end up switching. And let's say your provider is on board. You go over everything with your provider. They're like, yeah, no problem, completely on board. They may not be the one who's delivering your baby. A lot of doctors are in larger practices. One might be comfortable with a VBAC, one might not. I know that there's a practice here where one provider is comfortable attempting breech births. The other 9 doctors in the practice are not. So what if you don't get that person when you go into labor? Or if you want that person, you're going to want to induce so that they're your provider. So that also is another reason people get induced. They're like, I really love this one doctor. I really want them to deliver me. So let's schedule an induction. You're still not guaranteed to get them because inductions can take 2 to 3 days, especially if you're a first-time mom and if you're in a hospital that's patient and lets you go that long. There's some places that are like, time's up, we're doing a C-section. But I've been at a 3-day induction before, and the doctor was amazing throughout this whole induction. But you're still not guaranteed that they're going to be the one that delivers your baby. Another thing to look at is what's the hospital cesarean rate. I know that there's a hospital in Miami that the cesarean rate's like over 50%. So that's something to Google and to look up in your area. What's their cesarean rate and why? Like maybe your doctor or your practice's number isn't as much as that hospital, but it's like, okay, why are so many cesareans happening in this hospital? Also, I've seen providers flip their view during labor. This actually just happened at a recent birth that I was at where she had gone over the birth plan, was really hoping this one doctor was going to be there to deliver her baby. And she was. Like, it worked out perfectly. The doctor that she vibed with and loved was there. And she knew her birth plan. And then the doctor just like flipped during labor and was like, okay, we're going to start you on Pitocin. And then at this mark, if you haven't progressed, we're getting a C-section. And my client was like, no, and just was really advocated for herself. And then the provider didn't say it again. She actually backed off, ended up having a beautiful vaginal birth, and let her do that. But she was like not expecting that. She was definitely caught off guard and was like, wait, I thought that we were on the same page. I thought you had my back. Like, what happened here? So it can happen, but that's also why you have to learn to be able to be comfortable in your decisions and advocate for yourself. Another way of doing that is enrolling your partner. They need to be just as informed as you are. Research shows that an informed birth companion improves your whole birthing experience. So there's some people that maybe don't want a doula there or can't afford one. Sorry. Just got a little tickle in my throat. So research shows that even if you don't have a doula there, you can reap the benefits of having a doula by having an informed birth partner. So let's say it's your husband that's there with you. Enroll him in this information. This is my why. This is what's going on. Because if he is informed and he has a little bit of birthing knowledge, you still are going to get those benefits. Have a shorter labor, have less medical interventions, and an increased satisfaction of your birthing experience. So it's so important to get your partner involved, or a partner. Let's say it's a friend, it's your mom, it's somebody who's there, who knows your plan and is going to back you up on it. Hold on, I got a cough again. All right. I don't know what's going on there. When I get passionate, I like get going and then I feel like I'm losing my voice now. Okay, so here's a few objections that could come up. What if my provider says you can't go past this date? 39 weeks, 40 weeks, 41 weeks. You have a big baby. Your BMI is too high. We have to induce you. Your placenta is aging. These are all things that you can honestly Google, and there's going to be tons of information on that. Research shows these are not reasons to be medically induced. Unless for some reason you think that there's a certain risk that's too high and you're in the driver's seat, you're calling those shots, you're informed, and you're doing it. Let's say your BMI, for example. Research shows that if you have a higher BMI, you're more likely to be induced and more likely to have a cesarean. However, there's zero evidence that this has any indicator of your health, that it has zero evidence that this works. So the same moms that have equal BMIs in a midwifery model of care have lower induction rates and lower cesarean rates than those in obstetric care. What if I don't know how to advocate for myself, or I get nervous saying no? Or what if they threaten me? Hey, if you, like that story that I told, if you don't do this thing, your baby's going to die. Learning to advocate for yourself, once you start doing it, isn't that hard. Like I said, we see these doctors as these authoritarian figures, and they think that maybe you don't know anything about birth, but you do. The research is there, the information is there. You can find it and be informed and know how to make informed decisions for yourself. It's really not that hard to say no when they're like, hey, we want to induce you at 39 weeks. This is what's going to happen, blah, 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 blah. And you just say, no, thank you. Thank you so much for that information. No, thanks. I'm comfortable waiting until my body's ready. And you might get some pushback, and that's okay. But it's all about you trusting in yourself and knowing the research. But what if you trust yourself, your body, and your baby? Because they know what's up. There's actually some really great research that shows that when your baby is, the last thing to develop is the lungs. So once the lungs are fully developed, they release a chemical that sends you into labor. So even if your baby's 40 weeks, their lungs still might be working a little bit. There's not a hard timeline. It's pretty crazy to think that at 40 weeks, every single person's ready. That would mean that every single person conceived on the exact same day of their cycle, that every single person's needs and baby and everything is exactly the same. The development for every baby of every minute of every second is exactly the same, which just is not true. And so I also want to talk to you guys. I'm inviting you also to work with me in other ways as well, as I mentioned at the beginning. So my birth plan e-course is going to be coming out at the end of October. I know a lot of people who signed up for this are going to give birth before then, and I'm so excited for them as well. But if you're giving birth after October, you can sign up for this course for the pre-sale. It's going to be limited spots for $47. How we went into detail over things to include to reduce your cesarean rate. We're going to go into detail on every single one of your options over a birth plan and what you can do. So I'm really, really excited for this. And I'm going to give you guys a code, which I have somewhere, for the pre-sale as well. And then another way that you can work with me if you want to learn more is one-on-one coaching. I do 90-minute prenatal coaching calls, which are normally $250. And then if you book in the next week, you can do it for $150. And it's really just to get educated on your options, your individualized birthing experience that you want, and to receive research-backed evidence on routine interventions that can happen. And then for those of you that are here, you guys can get it for $100 if you book it in the next 24 hours. I am limiting my schedule, so I'm only taking certain calls up through October, because then I will also be having my baby in November. And then I will, let's see, the code for this one for the next 24 hours is coaching 100. And the code for the other one is birth prep 150, which I will send in a follow-up email as well for anybody who wants to book that. All right, so we're going to go over the winners of our things here. So anybody here, is this anybody that's here? You can put it in the chat. Let me see. Me, Charlotte won one. Very, very cool. Okay. So if you are a winner of this, you can reach out to me and I will get you that information or get information from you to send it. And then we'll go from there. All right. So I wanted to open it up for a Q&A before we end, just to see if any of you guys have any questions about any of the information that we went over, if anything came up for you, and all of that. You guys can either unmute yourself and ask or send it in the chat. No questions? I feel like somebody has to have something. When is it too late with providers? So I'm guessing that's when is it too late to change providers? That's what I'm guessing you're asking, Francesca. So it depends. I always say it's never too late. However, there are certain practices that don't take on new patients. So like how I shared earlier, that one practice that has the one doctor that does breech birth, they're so busy right now, they aren't taking transfers. They aren't taking transfers of care. So that can be the tricky thing that really sucks. There's a lot that plays into it, such as even like your insurance, where you live, access. There's places where people live where there's not access to different providers. I know even where I grew up, there's one hospital. The next one is hours away. So you really are limited on choice, which is why it is so much even more so to like be informed on this. But other places you can transfer late. I'd say if you're not comfortable with who your provider is, do your research, call around, see if you can transfer. And then if not, really, really go in equipped, knowing what you want and feeling empowered to like go like making those decisions for you. Anybody else? When looking for a new provider, do you need to meet them in person in order to find if they're a good fit? Any good resources or websites to read reviews, or is it common to make a virtual appointment to ask these? Some places don't even do virtual appointments. So meeting in person is always good. I would start with word of mouth. So finding a friend who had a birthing experience similar to what you wanted and who had a provider that they loved. But that can be really hard. I know I'm just using like breech as an example. There's only a few in our area that will potentially attempt a breech vaginal delivery. Doesn't necessarily mean that they will. Some of them that will are still bound by hospital policy and things like that. But you can always schedule an appointment at another place if they're still taking clients, see how that vibe is. I wish that there was a good resource. I do look at reviews sometimes, but also that can be really hard, right? Like, how many of you have your favorite restaurant and there's the people who like leave terrible reviews? Like, you're like, what? How could they not like this food here? It's amazing. Some of it can be very nuanced, but you might see comments in there like, you might see that there was a lot of C-section comments, or that there was a lot of, I didn't want to get induced, but they told me I had to type comments. So you can definitely look at that. One thing that I thought would be really, really fun to do, because Vito, my husband, was telling me how in college they had this thing called Rate Your Professor, and you could go in and rate your different professors. And like, how cool would that be to set up a database of maternal care across the United States? And you could find like who has low inductions, who has low cesarean rates, who has low this, based on what people are rating, and find a provider that works for you. So maybe one day I'll hire a web person. I don't even know what they're called, some sort of tech person to do this for me. But I thought that would be like really, really cool to have, because it can be really hard to find a good provider. So no questions, but have you witnessed any breech births? I have not. I've never been live at a breech birth happening. However, last year I did bring on Dr. Stu Fishbein onto my podcast, and he delivers breech babies. He teaches all about it. Love him. And that's like honestly one of my fears, even now as a doula, knowing my options. My baby was breech at 20 weeks, which doesn't mean anything. But I'm like, what if my baby's breech at the end? Because I would risk out of the birthing center. The state of Illinois does not allow breech birth in birthing centers. And at that point, it'll be too late for me to transfer to a home birth midwife, because they are very, very busy. You pretty much have to book out like months in advance. So I'm like, what are my options? I'm like, Dr. Stu, any chance you want to like fly out to to Chicago and deliver my baby, but I'm an hour from Wisconsin, an hour from Indiana. They both allow breech births, but that's like where I'd start looking because options are super limited when it comes to that. When trying to find a doula, where can one look? Is there any local Facebook support groups? So for finding a doula, there's a couple of things that I like. Doulamatch.net is a place to look, and you can kind of base that on your income as well. But I'm a huge fan of like asking tons of questions before you hire them, and also of word of mouth. My favorite is word of mouth. If your friends had a doula, if anybody had a doula, ask them where they found their doula, how their experience was, what they were like, because unfortunately, I've heard some terrible doula stories, and it like breaks my heart because I'm like, that's not what we do. This isn't the work that we do. Like, I know somebody whose doula sat in the corner and knitted the whole time, like wasn't hands-on, didn't do different things. And I'm like, oh my gosh, please don't think that's what we do, because we do so much more than that. But I have heard doula horror stories. So, and that's again with the provider. When I talk about obstetric care and midwifery care, you still have to do research, because the one birth I was at, it was a midwife who came in and said, your baby's going to die if you don't get a C-section, which was not true. So that's like across the board, like really word of mouth, asking people, finding somebody who fits your vibe. So I'd say word of mouth is probably the best one. What's the best format for bringing your birth plan to the hospital? A printed out document, or do some hospitals have an online setup? So to my knowledge, no hospitals have an online setup. I actually printed out, let me grab my birth plan. I printed it out earlier. So I have it right here. Okay, so I'm a big fan of one-page bullet points. I'm going to be developing a template, but I have not yet. I'm honestly not a fan of some of the ones out there that have different pictures and it's pages worth of stuff and paragraphs worth of stuff. I think that when it's simple, it's one page, it's bullet points, it's easy to read. That's my favorite template. So mine is you put your name, your partner's name, your birth plan, your postpartum, in case of induction, in case of cesarean. So the postpartum is also the newborn care, and it's very simple bullet points. You don't have to like elaborate on it. So it's, so for, let's say, in case of induction, my 3 points are breast pump made available, so that if my contractions are stalling, or let's say something happened, my water broke, I hadn't gone into labor in 48 hours, now I'm, at risk for infection, I need to get induced. I would use the breast pump first. Prefer not to use Pitocin, time alone with my partner, and different things like that. So that's the template that I prefer. And it makes it really easy. Your nurses want to read this. They want to know what you want. But when you have like pictures of different things and they're not sure what it means, or paragraphs of stuff, that can sometimes make it a little bit harder for them to help you out. How does one look into different local birthing centers? So again, that's limited. It depends on where you live. I know here outside Chicago, we have 2 or 3. So I would first of all start Googling what's in your area, and then go from there. So finding out what birthing centers are available to you. I've heard so many amazing things about birthing centers. There's been like one birthing center that I've heard like stuff about, and that's like in another state, one that I don't even like, I've never been to, so I'm not sure. So again, like just doing your research, asking anybody if they've birthed at a birthing center, what they recommend. Most of them have tours as well. They have birth center tours. Because of COVID, they also do virtual ones online. So you don't have to like go check out individually each of these places. But I would just start with Googling if there's one in your area. Facebook groups, that's a good place to ask for it as well. For people who may not have a doula to help educate and advocate for them, where do you like to find your research-based evidence? That's a great question. So evidence-based birth is going to be one of my number one resources. That was the chart in here that I included with the stillbirth rates based on age and gestational weeks. Evidence-based birth, you can literally Google, they go by EBB, evidence-based birth. So you can Google EBB or evidence-based birth due dates, evidence-based birth big baby, evidence-based birth gestational diabetes. Like you can Google almost anything. And it's Rebecca Decker. She used to be a nurse and then she got her doctorate actually. And so it's Dr. Rebecca Decker. And she's so passionate about breaking down all these trials, all the research, and just sharing the information. So she's going to be one of my absolute favorite resources to go to. I refer her information to people constantly. Would I be comfortable sharing my birth plan, finalizing mine, and still trying to figure out the best format? So I want to say on one of my blogs, let me make a mental note for myself. On one of my blogs, I shared it when I was pregnant with Jovi. I believe I shared my birth plan. So let me make a mental note here because I can include it in the follow-up email after this as well, that you guys are going to get tomorrow with the link to the video, with links to everything else that we talked about, will be in there. But yeah, I think that, again, just kind of for your labor, what you want, postpartum, newborn procedures in case of induction, in case of cesarean. That's usually what I include in mine. And then those bullet points. And it goes into like, again, things to research. So if you're like, oh, newborn procedures, what do they do? Well, erythromycin's one. So that's that eye ointment that they put on your baby's eyes. And you're like, wait, what's that? I didn't even know that was an option. What's going on? And you start to research and learn. And then you can make informed decisions on what you find on all these different things. So I can definitely share mine. What we chose for us might not be what you choose for you. And so I want you to know that too, that there's, it is very individualized. And I think that it is really important that each person figures out the risk and the information for themselves, that like I was saying before, for some people, a 1% increased chance of something happening might be like, I don't want any chance of anything happening. So yes, like do whatever you need to do. Other people might be like, you know what, I'm comfortable with that. I'm comfortable waiting. So you really just have to figure out what's best for you. Any more questions? No? Okay. Hold on. Could everybody drop their email that they signed up with in the chat really quick? And I'll have something special for everyone who showed up live here today. Just so I make sure I'm sending it to the right one. All right, I think we're missing one. Cool. Well, I want to thank you, everyone, just so much for your time and for showing up here and going through this with me. I know that I do get really passionate. So sometimes I'm like, oh my gosh, was I just like rambling about this one thing forever? Because I just feel like somebody says the word birth and I'm like, what? I could talk forever about it. So I just want to thank everybody for your time and for coming here today. I hope that you found this useful. You can always reach out to me through the emails that were sent to you. You can reply back to those. You can DM me as well. But I just want to thank everybody here. And I'm so excited for everyone on their birthing journeys. And I always love to hear birth stories. So reach out to me after you have your babies and let me know how everything went.
Thank you, Liz.
Yes, you're welcome.
Yeah, this is great.
Yay. I'm glad you guys found it informative. All right, everyone have a good night, and you will get, again, a copy of this and a little something in an email for you tomorrow. All right, good night, everyone.